In today's lecture at Medical Sciences, we want to talk about iron deficiency anemia. And iron deficiency anemia is the most common cause of anemia in the world. And it belongs to the type of morphological classification which is known as normocytic, that is microcytic hypochromic type of anemia. So it is the most common cause of microcytic hypochromic type of anemia, as we shall see it under lab diagnosis. So in this session, we want to discuss the etiology. We shall look at the sources of iron, what is the importance of iron during blood red cell formation. Then we are going to see the causes of iron deficiency and signs of iron deficiency. So we are seeing that iron is a constituent of heme, and this iron we are talking about in this session is the one responsible for it participates, or it is the one that is among the requirements during erythropoiesis. It is among the requirements during erythropoiesis, whereby erythropoiesis is blood red cell formation in the bone marrow. This one occurs in the red bone marrow. So during erythropoiesis, we need iron for these erythroblasts to differentiate and mature into a red cell which can be able to carry hemoglobin. Because we're going to see, in case of deficiency or low levels of iron, we know during heme synthesis, when the body is synthesizing heme, ferrochelatase enzyme comes and incorporates iron at the center of heme, and that's why each heme, this is 1 molecule of heme, and 1 molecule of heme, it carries 1 molecule of oxygen. So it is the one that gives the oxygen carrying capacity of heme. So when it is deficient, meaning this hemoglobin will lack this iron, which gives hemoglobin a red color, and even we shall see under lab diagnosis that the red cells will be paler, that is hypochromic. After seeing the importance of iron and being the most common cause of microcytic hypochromic type of anemia in the world, where do we get this iron from? This iron can be got from food. We can eat iron in food, whereby the source of iron is vegetables, fruits, meat, liver, and so forth. So when we eat it in food, another source of iron apart from eating it in food is from metabolism, or it is from breakdown of red cells after 120 days. We're going to see after 120 days, even RBCs are broken down to give heme, and heme contains iron, which we have seen that heme contains iron. So there are only 2 sources: dietary, that is through food we eat, which is the most common source of iron is from breakdown of RBCs when they reach their senile stage. And after seeing the source, we're going to see when we have iron, when we ingest iron in food, and this iron is ingested in form of ferric, it is in iron 3 form, it is ingested in ferric state, and this iron in ferric state is transported inside it is absorbed in the duodenum and the jejunum. And within the duodenum, we are going to see in the intestinal walls or in the duodenal walls, there is a transporter, and this transporter is known as divalent metal transporter type 1. It has an enzyme known as ferroportin reductase, which first reduces this iron 3 to iron 2 in ferrous state, and after forming ferrous state, this transporter known as divalent metal transporter will transport inside into the duodenal wall this iron in ferrous state. So we are seeing this iron in ferrous state is transported inside the duodenal wall by divalent metal transporter type 1 after being reduced by ferrous reductase to ferrous iron. And this iron too, in the duodenal wall, it has to move and enter into the blood saturation, that is in plasma. So what happens, there is another enzyme here, an oxidase enzyme, and this ferroxidase enzyme is going to catalyze the oxidation of this iron 2 again to iron 3. So this iron 2 is again converted to iron 3 by ferrous oxidase on the basolateral side of the duodenal walls. So after this iron 2 is converted to iron 3, this iron 3 moves through blood saturation. So in blood saturation, we find still iron is in ferric state, and in saturation, it is transported bound to transferrin. Transferrin has receptors where iron binds and is transported. So we are going to see the major carrier protein for iron is transferrin. And this transferrin transports iron 3 in plasma, and then it brings it to the liver. So the transporter is transferrin. And when it reaches in the liver, this iron in the liver, if I can zoom this liver, it is stored in liver as ferritin. So in cells, it is stored as ferritin or hemosiderin. So this is the iron stored in the liver, or it can be even transported directly to the bone marrow and stored there for use. And it is stored as hemosiderin or ferritin. So the storage form is ferritin or hemosiderin. That is whereby ferritin is an apoprotein combined with iron to form what we call apoferritin. That is what we can talk about under this. So we have known the transporter, transferrin. We have known the storage forms, that is ferritin and hemosiderin. So under iron profile in lab diagnosis, we shall see how these guys play a big role in diagnosis and confirmation of iron deficiency. So we are seeing this ferritin or hemosiderin, they are stored in the reticuloendothelial system. That is the liver, spleen, and the bone marrow. And in the bone marrow, we are going to see in the ends of red bone marrow, that's where it is stored as ferritin. And we are going to see another test we can do, which we can call Pearl's Prussian brew, to confirm presence of iron in the bone marrow. So when someone is deficient of iron in a severe stage, and we get a bone marrow smear, we stain it, we find it is Pearl's Prussian brew negative due to the depletion of iron stores in the bone marrow. So after understanding this physiology of absorption and transportation and storage of iron, whereby under transportation, we have seen it is transported in the duodenum, it is absorbed, eaten in food, or from the broken RBCs, it is absorbed by the divalent metal transporter. Then after being converted to ferrous state, then as it is leaving the duodenum in the basolateral side, it is reoxidized to ferric state, which is transported by transferrin protein, and it is taken to the reticuloendothelial system, that is liver, spleen, and bone marrow, and is stored as ferritin or hemosiderin. So that is what we can talk about. But some small portion of ferritin is also found in plasma. That's why we shall even assay what we call serum ferritin, because it is also synthesized in the plasma. And we shall tell you that sometimes the ferritin can be affected by, it is an acute phase protein, and we shall see how it is affected by certain conditions. So after looking at this pathophys and the function of iron, how it is important in erythropoiesis, now we can talk about what causes iron deficiency anemia. It is a puzzle. What causes? And they are categorized into three. It can either due to decreased intake of iron. It can either be due to increased demand, or it can be due to chronic blood loss. So these are the three ways which can cause iron deficiency. And under decreased iron intake, this is whereby you are taking food without iron, like the vegetarians or the vegans who don't take meat, they can easily suffer. So this is due to malnutrition, whereby someone is taking food without iron. Then increased demand, this one is seen either in pregnancy, whereby in pregnancy there is increased demand, or in growing children, whereby there is increased demand for iron. So this one can lead. That's why we find iron deficiency common in pregnancy and in growing children. Then under chronic blood loss, we can see it in hookworm infection, hookworm infestation. We can see it in menorrhagia. What is menorrhagia? This is prolonged menses, whereby someone goes in menses for more than 10 days. That is what we call menorrhagia. And even the people with severe PUD, peptic ulcer disease, whereby there are wounds in the stomach or in the GIT causing intermittent bleeding. And even we can see another cause of chronic blood loss is presence of carcinomas in the GIT. So if someone has any cancer of the GIT, it can also bring about chronic blood loss, which at long run will cause loss of iron. Because when people have these challenges, the absorption is poor. Absorption is poor. And actually that one can be another point. Sometimes it can be malabsorption. Malabsorption. Yes, you are taking food containing iron, but it is not being absorbed into blood to be seen. So in case of malabsorption due to these conditions or due to increased blood loss, we can see iron deficiency coming. And among the signs and symptoms, if we can look at signs and symptoms of people with iron deficiency, the first thing, they have shortness of breath. There are those which are common, that is general signs like shortness of breath. Shortness of breath. We can see palpitations whereby there is increased heartbeat. You feel the heart pumping. Then there is koilontia, that is spoon-shaped nail. Spoon-shaped nail is also another peculiar sign of iron deficiency. And other symptoms we can see brittleness, whereby someone has brittle hair or nail, whereby the hair is breaking and dry nail. Then another common feature is paleness. Someone has pale skin, pale mucous membranes. That is also another thing. Then lastly, we can see is glossitis. Glossitis, that is atrophy of the tongue. lamina. So you find the tongue is peeling off. Another sign we can see is angular stomatitis, whereby angular stomatitis is blackage of the corners of the mouth. You find someone, the corners of the mouth, they are blacking. That is what we call angular stomatitis. So these are the signs and symptoms, whereby there is shortness of breath, palpitations, spoon-shaped nail, brittle hair, skin or nail, paleness of the skin, and then glossitis, that is atrophy of the tongue, lamina, and angular stomatitis. Those are some of the peculiar signs of iron deficiency. So after looking at the causes and signs, now we can go to the lab diagnosis. If we have known the cause, we have seen the signs and symptoms, and we have seen the pathophysiology. So how do we diagnose someone with iron deficiency? The first thing here, the samples we use, the lab samples we use, we can use whole blood, we can use plasma, whole blood collected in EDTA tube, or we can use serum collected in red top. These are the two samples we use. And sometimes we can also do stool depending. Even the stool, we can use it to rule out hookworm infestation. So those are the samples. And after getting these samples well collected, we do a CBC, which we call complete blood count. And under complete blood count, we are going to find under RBC, we shall find total RBC count is low, or sometimes it can be normal. We shall find HB concentration is between maybe 6 to 10 grams per liter. We shall find on this CBC that MCV, that is mean cell volume, is also less than 80 femtoliters. Then we shall find MCH is also less than 27 picograms, and sometimes even MCHC, that is mean cell hemoglobin concentration, is also less than 32 grams per deciliter. So when you find someone's CBC, they have low HB, they have low MCV, MCH, and MCHC. And another thing which confirms here is RDW. When RDW is high, that is greater than 16%, that one we can suspect iron deficiency. We don't confirm, but we suspect. Then you will find on the total white BC count, it is normal. And the differential count is also normal. Even the platelet count is normal, or it can be high if the cause is bleeding. If there is chronic bleeding, we can see platelets when they are high. And there are other features we can do to check for the presence of iron deficiency, where we can even do Mentisa index. So here we can even do Mentisa index, whereby this Mentisa index is calculated by getting MCV and you divide it by total RBC count. When you get MCV of that CBC you have got, and you divide it by the total RBC count, and you get the ratio, Mentisa index ratio, greater than 13. This one suggests iron deficiency anemia, and less than 13, it suggests thalassemia. So this Mentisa index is used to rule out or to differentiate between iron deficiency and thalassemias, which are all causes of microcytic, hypochromic type of anemia. So that's why we say that people with iron deficiency, they have hypochromic microcytic cells, as we're going to see it under thin film comment, whereby under thin film comment, we shall see the cells are microcytic, hypochromic. That if we can draw a picture of a PBF, and this is a resting lymphocyte, this is a resting lymphocyte, you're going to find that these RBCs are small in size with a big area of central pillar, and some of them we shall find there elongated cells without area of central pillar, and these elongated cells are what we call pencil or cigar shaped cells. So these are microcytic hypochromic red cells. The area of central pillar is greater than a third. It has a bigger area of central pillar, and even the size is less than 6 micrometer. Then also there is presence of pencil cells, or you can call them cigar. They are cigarette-like, cigar or pencil cells. So another finding under PBF, we are going to see poikilocytosis of pencil cells in a thin film. This one is the one that distinguishes thalassemia also from iron deficiency, whereby in iron deficiency we see pencil cells, then in thalassemias we see target cells. So these are the pencil cells. They look like a pencil. They are elongated without area of central pillar. Then the others which are normal, they are small in size with large area of central pillar, and small in size compared to the nucleus or a small resting lymphocyte. So these are the key peculiar features we can see under the PBF of iron deficiency anemia. So after looking at that, we can look at also serum iron profile. Whenever you get a CBC like this, you get a film comment like this, and you have done even your Mentiza index, the confirmatory test is serum iron profile. This is the confirmatory. This is the confirmatory test, whereby under serum iron profile, we are going to do a key tests like with this serum iron. We can do serum ferritin. We can also do a test known as total iron binding capacity. We can even do what we call serum transferrin saturation. So these are the tests under this profile, whereby with iron deficiency, people with iron deficiency, when we assay the serum iron, we find it is low. It is low, whereby the reference range of iron is between, the normal range is between 50 to 150 microgram per deciliter. So you find these people have less than 50. Then for ferritin, the normal range, you will find also serum ferritin is low. And when it is low, this one implies that the iron store is depleted. The store of iron is depleted, and it is depleted when it is below 15 microgram per liter. The reference range or the normal range is between 15 to 300 microgram per liter. Then you find the total iron binding capacity is raised. For it, it is raised. Why is it raised? if the iron is little, so the ability or the affinity to bind is high because the binding sites on transferrin, they are free. So they are hungry to bind. That's why the total iron binding capacity is raised, whereas others are low. And even here, the transferrin saturation is low, that is below 30%, whereby the reference range is 30 to 40%, because this transferrin has binding sites where iron attaches to be transported. So this is the lab diagnosis. And the lab diagnosis, we talk about the CBC, complete blood count. We have even gone ahead to do Mentiza index on the CBC. Then we have seen the PBF, that is peripheral film comment, whereby you have seen microcytic hypochromic cells. Microcytic because MCV is low, hypochromic because MCH and MCHC, they are low. Then RDW is high due to the different shapes. So there is even some anisocytosis. Then we have the confirmatory, which is serum profile, serum iron and ferritin, they are low. Then the total iron binding capacity is raised. So these are the ones that confirm that really someone has iron deficiency. Or you can even go ahead and also do bone marrow smear. And when you do bone marrow smear and you stain it with the Pars Prussian blue, it is Prussian blue negative. Pars Prussian blue negative. Meaning also there is no hemosiderin in the bone marrow. So the storage is depleted. So even you can do bone marrow smear. Lastly, under iron deficiency, we can discuss also treatment. Treatment is majorly knowing the cause. Apart from giving iron supplements like ferrous iron in supplements, you can, so there are many tabs which they are called hematinics. So these ones are being used to treat iron. But apart from that, it is better for a doctor to know the exact cause. If the cause is hookworm infestation, then you need to treat it first by deworming, whereby you do stool analysis. If the problem is menorrhagia, then stop the bleeding. That is prolonged menses. If the problem is PUD, that is peptic ulcer disease, treat the PUD or the carcinomas. So the treatment can also be due to according to the signs, according to the cause. You treat according to the cause. That is what we can talk about. You can treat according to the cause. Then if it is increased demand, then there we can give the supplements. And if it is a decreased intake, we can advise these people to take some meat, liver, fish, and so forth to be treated with iron deficiency. Thank you so much for learning at Medical Sciences. Hope you have gained a lot from this session. May God bless you, and remember to subscribe and like the video.